Perfect. Okay, well, welcome everybody. It's my pleasure to host Grand Rounds this morning virtually. Just a couple announcements before we start. The first is I hope you can see the slides for Pediatric Grand Rounds. The next 4 weeks at least are going to be dedicated to COVID. Next week, Bonnie's going to give us an update on the virus, and then the following weeks, we're going to talk about topics such as advocacy and what we can be doing for our community, as well as education, impact on our learners. The other, and I want to give a special thanks to the Pediatric Grand Rounds Committee that's right on top of all of this. I also want to make sure everybody's aware about the changes in the Department of Medicine Grand Rounds that are held on Wednesday morning. That now has been converted to a forum to serve the entire Stanford community. So please log on for those as well. They give updates on the SHC side, and we'll be starting to include some updates on the Packard side. But that's a nice opportunity to hear about the science, the epidemiology, and just a broader opportunity for the community to hear together. As you note on the slide, you can text here to get your CME. And with that, we'll move on. Let me just say a little bit about the instructions. The main thing is that we ask that any questions that you have, you type in the chat box. I'll be keeping tabs on those over the course of Jason's presentation. And then at the end, we'll have some time for some questions. So with that, I'm gonna move on to introduce Jason. Jason, just a little bit about his background. He did his bachelor's at MIT, went to medical school at Harvard, has a PhD from the Rand Graduate School, his PhD's in public policy analysis. He was a Robert Wood Johnson clinical scholar. He has all sorts of other very interesting and practical experience. You may hear about some of it. Some is his role as the project director for the task force on reforming Taiwan's national health insurance system. And as part of that, he set up the Office of Healthcare Reform. He also is co-PI of Taiwan's birth cohort study of over 20,000 children from birth. They're now 12 years old. He was on the faculty of Boston University, and then we were very fortunate to recruit him here in 2011, and eventually he assumed the role, took over with Paul Wise as the director of the Center for Policy Outcomes and Prevention. And he's also, I hope you know, the co-director of the PCHA-UHA Learning Health System using our network for research. His scholarship has many areas of emphasis. I know you'll only hear about part of that today, but you should know he's doing great work applying mobile technology and telehealth to facilitate access to care, developing tools for measuring quality of healthcare for children, using data to drive delivery change, and a variety of other topics. And then Jason, the other thing I learned by reading your CV is that when you were doing some work at McKinsey, you got the award for the most committed person and the most likable person. So I agree. Okay, with that, Jason, take it away.
Thank you so much, Mary. And it's a pleasure to speak at the Pediatric Grand Rounds. This is home for me. And today I'm going to talk about how can a democracy effectively respond to COVID-19, lessons from Taiwan. And I'm part of general pediatrics and also primary care outcomes and research and medicine, and of health research and policy. So I'm gonna give a little plug to our field in general of health policy. So our center, the Center for Policy Outcomes and Prevention, which was started by Paul, we study policies to produce better outcomes and prevention. So that's what the center is about. And it's part of the greater Stanford health policy. As part of that, we analyze data and try to value different policy options and trade-offs, and to identify policy levers that we could act on. And finally, to formulate conceptual frameworks and strategies to teach and hopefully to train the next generation of policymakers or policy analysts. And at Stanford, we have an academic journal pediatric training program, and the fellowship is directed by Janelle Abbey and co-directed by myself. I'm also part of the NIDDK Rapid Training Program for underrepresented minority scholars interested in academics, and that's with Dr. Fernando Mendoza and Glenn Flores. And more recently, we've started a new school for leadership in healthcare, which is based in Taiwan, and we're going to be training folks in Asia. And so, this current story actually came from my trips to Taiwan I go there monthly, usually for 3 days. And I usually take different faculty members from the US over there to co-teach with me. And so this is sort of the curriculum that we offer at the new school. It has healthcare management courses. It has health equity topics, quality in healthcare, future of healthcare in medicine, such as AI and machine learning techniques, and public health and prevention. That includes public health crisis management, which is what we're going to talk about today, and principles of epidemiology and infection. And it also has topics such as drug development and study design and so forth, translating research into policy. And in the last half year, I think from Stanford, Nigam Shah has gone with me, Nirav Shah has gone with me. In the past, Dr. Abraham Verghese has gone with me. And in my last trip in January, I went with the Vice Dean of Johns Hopkins, Dr. Joshua Sharfstein. And actually, we were there to teach public health crisis management in January and drug development. And on the way there, we were watching Chernobyl on the airplane. And so we're thinking, wow, how did they deal with that crisis? So we were on the way there watching it on the way back, and we finished it on the way back. And just about the same time, now my return trip was January 12th. And I was already thinking about the next trip in February. And just about that time, there was this new coronavirus that might be coming from China. So this is a map of Taiwan, and it's 81 miles from China. So basically, that's like from here to Monterey. So it's very, very close. And as you could see, there's lots of traffic. There are 2.7 million visitors from China in 2019. And there are almost, daily, flights are full of visitors. And about 850,000 Taiwanese live in China, and they go back and forth. So this is the issue that we're dealing with. Now, if there's something that's from China, it's going to be in Taiwan almost immediately. Now, Taiwan is also a vibrant democracy. In January 11th of this year, 2020, there was a presidential election with two major parties. One is the Democratic Progressive Party, which is the incumbent party, and the Nationalist KMT party. Now, KMT came from China. And so in 1949, KMT fought a civil war with the Chinese Communist Party and basically was defeated. And now they then moved to Taiwan to regroup and with the hope of regaining China from the communists. And so these two had a very contested presidential election just in January 11th of this year. And this is right outside of the presidential office. This crowd estimated to be about 500,000 people each. So this is where the crisis started in Wuhan. Wuhan is a city with a population of 11 million. It's China's seventh largest city. And now it was thought that there was this market called the Wuhan Wholesale Seafood Market on the top. And it was also thought that this coronavirus came from bats. And bats are served as food, both in parts of China and also in Indonesia. And so it was about around this time in early January that there's this doctor called Dr. Li Wenliang at the bottom. Now he's noticed that he's seen a lot of people coughing with unusual pneumonia, and basically he himself got it. And he said that, well, I've never been to the market, the seafood market, and so did 7 of my other colleagues that's practicing medicine, and they've never been to the market, and they are having this pneumonia. So he wrote this up in social media, and then he was reprimanded by the party for spreading rumors about this virus, because at the time only people who have been to the market and have pneumonia are considered to have the possibility of getting coronavirus. So this human-to-human transmission, people didn't believe that. Now, as everybody here probably know, that Wuhan then was locked down and people were locked in. And basically all the streets were closed with police patrolling. All the buildings were closed and some of them locked, so people couldn't really get in and out. But before the city was locked down, 5 million of the 11 million people had left. So somebody knew the information that the city was going to get locked down, but the people who didn't know get locked in. So this was when right before the travel restrictions and imposed before the Lunar New Year's. So I moved to this country when I was 12 years old from Taiwan, and I still read a little bit of Chinese. So I was reading their reports, and it's very interesting. This is a very smart virus. During the Communist Party meeting from January 12 to January 17, no cases reported. But after the party has adjourned, cases started to get reported from 4 to 77 in 2 days. Now, this virus apparently also does math. Every day from January 30th to February 5th, the case fatality rate is always 2.1%. Now, look, when you're dealing with such a smart virus, you have to be very, very careful. So this is when we did we decided, and basically in order to make sure that the visitors that are coming with me to Taiwan are safe, I started to compile very detailed information about what the Taiwanese government was doing, how many cases they were getting, and try to see if I should go in February. And this is how this paper started. And I did not expect that in a couple of weeks it had 671,000 views online, and had received a lot of attention. And I think Taiwan, because it's so fundamentally different from China in that it's a vibrant democracy. And my question was, how can a democracy deal with this kind of issue? You can't really just have lockdowns and lock people in. And so this might serve as lessons to some of the other democracies dealing with this issue. So let's go back a little bit, back to when Asia was affected by SARS, and this is 2003. So during that time, and SARS, as you know, is a coronavirus. And so during that time, China suffered a great deal with 349 deaths reported. Hong Kong too, it was 299 deaths, and Taiwan was the third, 73 deaths. And Canada, also our neighbor, 43 deaths, and Singapore, 33 deaths, and Vietnam, 5 deaths. So a lot of countries have suffered a great deal from SARS, and people were alerted with coronavirus because this is something that was new and people didn't know how long it was going to last and so forth. So I'm going to share a video with you.
Every week, tens of thousands of people travel between Taiwan and mainland China, yet there are fewer than 80 cases of COVID-19 in Taiwan. The health minister says the Taiwan CDC has been preparing for this for years. Both Canada and Taiwan saw their first people infected with the coronavirus within days of each other. But in March, Canada's cases surged, while Taiwan creeps up only incrementally, even when adjusted for its smaller population. This analysis of Taiwan's response to COVID-19 credits the island's health officials for taking action early, boarding flights and screening for sick passengers. Passengers now fill out health questionnaires on their phones while at the gate.
They could triage large number of passengers very quickly without having them lining up in the airport.
Taiwan also tied together electronic patient files to immigration records, following up with those at risk based on their travel history, texting them to self-isolate if needed, and checking up in person, threatening fines if orders are ignored.
I think in the Canadian context, that would be viewed as rather dystopian.
This doctor says Canadian privacy legislation would make Taiwan's level of data collection impossible. But she says Taiwan did the right thing with masks, banning mask exports and price gouging. The military even took over mask production.
I was actually kind of admiring that because my struggle with not having masks in my office has been an ongoing one for the past month.
Taiwanese in self-isolation are delivered food and other supplies, as well as home visits to check on their welfare.
At least you're treated like a person and not a virus.
It's the combination of small gestures and big data that's given Taiwan an unprecedented edge over other countries in controlling COVID-19. Vic Adopia, CBC News, Toronto.
So Taiwan hasn't always done so well. And I think because they learned from SARS in 2003. So what happened during SARS? 94% of all known infections were transmitted inside hospitals. Let me repeat that. 94% of all known infections were transmitted inside hospitals. And all major hospitals were fully or partially shut down. Doctors and nurses quit for fear of catching the disease because of inadequate hospital infection control. Fever clinics set up too late outside of hospitals to prevent infections in waiting rooms. Infected laundry workers at one of the hospitals became a super spreader, a laundry worker. Entire Hoping 450-bed hospital was shut down to quarantine all 930 staff and 240 patients. They were locked in the hospital. Quarantine patients in other areas evaded isolation despite threats of steep fines. This sounds really familiar right now. So we need to get prepared. And what's happening was that during that time in SARS in 2003, the Taipei city government was of a different political party than the central government. So they were playing different tunes. They weren't working together. So I believe that in cases like this, the central government and the local governments ought to work very closely together in order to avoid tragedy. Let's look at the economic impacts of SARS. So there were different estimates. If it were to last 1 quarter versus 2 quarters. And right now we have no idea how long COVID-19 is going to last. But initial estimates of the impact on GDP, for example, for Taiwan is, 1 quarter is 0.9%, 2 quarters 1.9%. And if you look at what happens in actuality, look at the 2003 estimates. The forecast was 3% and the actual growth, GDP growth was 3.3%. So it's not as bad as people had predicted, but there's some catch-up growth after the SARS epidemic. But the SARS epidemic didn't last that long. It ended around the summertime. But coronaviruses are very tricky and they mutate. So we really don't know how long this one is gonna last. And certainly what we're seeing right now, Singapore is pretty hot, but it's still spreading. So we have to be very careful and vigilant and do more conservative estimates of what's going to happen. So as part of the preparation for the next crisis, let me repeat that. After SARS, they were preparing for the next crisis. They started to have laws changed, the Communicable Disease Control Act. I highlighted some of the things that they did. They allowed the government to have protective equipment stockpiles. They created a central epidemic command center to unify and coordinate government organizations, including the local and central governments. They allow for regulation of gatherings, entry and exit of people, traffic, evacuation, travel restriction. They specify penalties for violating home quarantine isolation regulations, hoarding resources, disseminating rumors or incorrect information, fines institutions for employees' bad behaviors, allows for trafficking and management of people under infectious risk, mandates the geographic locations and total number of patients to be made public. And this is general locations, like, in your neighborhood, there was a few cases here, and in this other neighborhood, there were a few cases, so general locations. Allow for use of public properties and requisitions used for private land, productions, buildings, devices, facilities, pharmaceuticals, medical devices for disease control facilities for treatment of contamination, and to provide adequate compensation for those affected. Now, Taiwan has elections all the time, and about 75% to 80% of the people vote in these elections, including the presidential election. These kind of legislations are bipartisan. They will pass to protect citizens in a democracy because they know how quickly things could go wrong. Let me show you what the command center looks like. So the command center was created in 2004 after SARS, and it's a physical structure. It's on the 7th floor of Taiwan CDC. It was modeled after the WHO released Command Center Development Guidance in 2015 to modify it that way. It was created much earlier, but it modified the room so that it mimics what the WHO would recommend. It includes the Central Epidemic Command Center, the Biological Pathogens Disaster Command Center, the Counterterrorism Command Center, and the Medical Emergency Operations Center. And it could accommodate 100 people at a time. Now you could see that there's these lounges here, and people could basically huddle here, 100 people 24/7, and you could take a nap if you need to. And there's a situation room, there's a media watch room, so you could get press conferences. The way the command was set up was that there's the commander, and there's an information officer, and there are people in charge of logistics, people in charge of response, and people in charge of surveillance. And so in its actual operations, you see all these monitors coming in from different places, and all the data coming in real time from different locations in the country, including our international collaborators. And basically, they were cranking out data and using the data to make decisions for the next steps. And so it has the National Health Insurance stockpile system that includes, how much inventory they have. There is the Taiwan National Infectious Statistics System and the media surveillance system. So it also has information exchange with departments in other countries through the IHR focal point. So why is that important for people to be co-located? Let me just do a little simple math here. So let's say that you have 4 people and you want to communicate with each other. There are 6 ways to communicate. The formula is n times n minus 1 divided by 2. So let's say you have 20 government agencies. All of a sudden, just to communicate with each other is 190 different ways of communicate with each other. There is no way in a crisis that you could communicate that way. That's why you have to get the heads of government agencies in the same place, in the same compound. The second thing is that the picture on the right here is that, let's say you only have two groups. Each group has their employees, their subordinates. And so the communication is actually much more complicated, just 20 people. And it's basically an exponential way of communicating. So you really need 20 people sitting together in the same location, communicate constantly, and have their people feed them the information so that in the discussion, you have all the information. And this is just Taiwan, but in the United States, we are a lot more complex because we have 50 states and each governor has his own power and political affiliation. And we have lots of federal agencies that needs to coordinate with the governors, with the executive branch. And also, you know, we are in an election year. So how do we do this? Now, let's go back to medicine here because I think a lot of the residents have run a cold. Now, in a cold, you need a commander. You need people to write things down, what has been given. You need people to do stuff. You do the chest compressions. I will get the, you know, I will get the IV and so forth. So it's very similar to what we do in cold blues in the hospital, which is you have to practice. Even though when there were no codes, mock codes, we do mock codes. So you need to have a command center and prepare for a crisis. And so if you don't, you should set up one very, very quickly and have people start to share information real time. So this is what Taiwan has done this time. In December 31st, this is when WHO notified of a cluster of cases of pneumonia of unknown cause in Wuhan. Taiwan's health officials immediately that day, they went up to the airplanes that are coming from Wuhan. They start to check temperatures. They start to ask questions of respiratory symptoms because they didn't want another SARS. So after they started checking, they noticed that this is going to be maybe a severe epidemic coming up. They activated the Central Epidemic Command Center on January 20th. And then on January 21st, they placed Wuhan as level 3 travel alert. That means everybody who comes in from Wuhan has to get quarantined for 14 days before they could leave. Also, they had a National Security Council meeting to coordinate efforts from various ministries. And the next day, entry permits were canceled for all the tourists set to arrive from Wuhan. And Wuhan residents were banned and travelers from China required to make health declaration before entering. And then tours to China was suspended, and Hubei province, this is where the province where Wuhan is a city, Hubei is a province, was put on level 3 travel alert, and the rest of China level 2. Now the difference between level 2 and level 3 is that level 3, you are required to do home quarantine for 14 days. And level 2, you could do self-management, and if you have symptoms, the government will help you to get care. On January 27th, the National Health Insurance Agency integrates its database with the Immigration and Customs agency. So now, when a person enters, that travel history from the Immigration and Customs is now sent in batch files to the National Health Insurance database. So if somebody went to see a doctor, the doctor will get a pop-up and say, oh, your patient has been to Wuhan or Hong Kong or Macau in the last 14 days. And the doctor will do a more thorough history, maybe do the exam a little differently with more mask and gown, and maybe test the person for COVID-19. So this was done in January. They linked the two data sets in one day. And people say, well, how can you link the two data sets in one day? And the reason they were able to do that is because the government has a chief information security officer, which is the vice premier. And because they were constantly getting attacks, internet cyber attacks from China. So they had to secure all the government databases. So they know which database is where and what kind of information they have in there. So they were protecting all these key database assets, particularly during the presidential election. So this is another lesson for us, because they were preparing for the presidential election, so they secured the databases in all key government agencies. And when they needed the integration of some batch files from one database to another, they were able to activate that by the law of the Communicable Disease Control Act. Say, based on this law, we could activate and merge these data sets, not merge, but just batch files. And they actually got rid of the unnecessary data. They just kept the essential ones in the data set. So let me share with you another video.
Only a few dozen in Taiwan have become sick.
It had outperformed its expected, outcomes by a lot.
In the early days of the outbreak, the country used its national health insurance database and its customs and immigration database to start creating big data it could use to track the virus. If a person went to a clinic or doctor's office, that information would generate alerts based on the patient's symptoms and travel history. At the borders, those considered low risk were sent a pass by a text message allowing them entry. Anyone considered high risk was put into quarantine at home, tracked using their mobile phones to make sure they stayed there.
So this is part of triaging people in airports. So you have a lot of people coming in, you want to know if they're low risk or high risk, and you can't spend the same amount of time with everyone. So you have them scan a QR code that leads you to an online form, and then you fill out your travel history, your symptoms, if you have any respiratory symptoms or fever, and then your contact information. So the government could contact you. And this is part of the regulations. And so for people who are low risk, didn't travel to endemic areas, didn't have any symptoms, they got a pass, a text message say you passed, so they could just go. And those with high risk, they need to be quarantined for 14 days. Now, if you're quarantined, the government brings you food and they check up on you 2 to 3 times a day for symptoms. And if you get worse, or if you need medical care, the government will help you to get care. They will assist you through a special route to get care. Now, if you break quarantine, they will fine you, equivalent to several months of salary. And more recently, if you stay, the government asks you to do quarantine and you comply with the quarantine, they pay you. They pay you equivalent to your day salary, like a young person's day salary. So either you want to get paid or you want to get fined. And so it's both a carrot and a stick. And they use electronics, sort of new mobile technology to do some of the tracking, which I understand it's very sensitive to a lot of people. But this is a temporary measure. They don't get to do that when this is over. So it's one way. I think it's a trade-off, and definitely need to be looked at more carefully. So, what do you do with managing the crisis? Now you have them. So the first thing to do is to assess capacity. So on January 20th, the government did a quick inventory check, and they figured that they have 44 million surgical masks and 1.9 million N95 masks and 1,100 negative pressure isolation rooms. Now, everybody who was watching TV that day quickly did a quick math. 44 million divided by 23 million in Taiwan. That's like less than 2 masks per person. So after release this information, the government says, you know, we're going to stop exporting masks outside this country, and we're going to have to make more. And everybody quickly agree with it because there's a less than 2 masks per person. Yes, let's make more masks. So at the time, the daily manufacturing capacity was 2.44 million units. And they basically, if you're traveling abroad, you could not carry more than 250 masks. And certainly you cannot sell them as a vendor to profit from a crisis. And then they limit, there was a limit placed on the number of masks purchased per person, and they set the mask price to 27 cents. Okay. Now, as the manufacturing capacity was ramped up to 4 million units, and the government requisition of surgical masks, the price dropped to 20 cents. So if you want to buy a mask, now it's 20 cents, it's lower. So there's no point of hoarding. If you hoard, you just bought, you know, 27 cents and then now it's 20 cents. So nobody wanted to really hoard that much, maybe a little hoarding. But then they ramp up the production even more. And then the government invested 6.6 million to increase daily mass production to 6 million units and reserve troop aid in production. So the reserve, the military reserve was asked to work in mass production of masks. So right now, Taiwan could make 10 million masks per day, 10 million per day. Okay. And then an online ordering system was created, and you could actually order online and you could go pick it up in your neighborhood 7-Eleven or drugstores. So basically what's happening is that they've, before when people were lining up for masks, it was kind of dangerous because the line was very long. People maybe were coughing into each other. And so they say, okay, if your birthday is even number, you go Tuesdays, Thursdays, and Saturdays. And if it was odd number, you go Monday, Wednesday, and Friday. And Sunday, anybody could go. But now you don't even need to do that. You just order it online, you just go pick it up. So things as simple as masks is not that simple. So I'm just gonna tell you how a mask is made here. There are 3 layers, okay? There's the direct contact skin layer. That's the part that touches your face. The high density filter layer in the middle, that's the part that filters out bacteria and viruses. And the outer part, the leak-proof non-woven fabric, okay? Now, it turns out that the government quickly identified on the left all the suppliers of all these materials, where they are located. And then they told the suppliers, look, government is gonna need your supplies. And we activated the Communicable Disease Act, and we have we're gonna be using that. And all the suppliers says, that's fine, that's great, let's do it. And then there were a whole bunch of probably like 100 different engineers from that knows how to do machinery and tooling. They just volunteer their time. So in 3 weeks, they ramp up the production of masks from 2.44 million to 10 million a day. So securing the raw materials is important, and making sure the production line is working is also very important. So now it's the 2nd largest face mask producer. And the Taiwanese government will be donating 100,000 masks per week to the United States because of very friendly relationships with the US. So this is how they ration to stop the panic buying of masks. So so you use your national health insurance card to get the masks. And initially it was limited to 2 masks per purchase within a 7-day span. But as they ramp up, by March 5th, you could get 3 adult masks and 5 child masks every 7 days. So what does that mean? That means kids are back in school. They could go to school because during the time that this was happening, it was during the Lunar New Year's. So people were on holidays. So the government had decided, okay, let's make the winter vacation a little longer. Let's extend it by 10 days so we can get ready for school. So during the time they were ramping up mass productions, and then they had all these videos with the vice president, who is an epidemiologist trained at Johns Hopkins. And he actually was the former dean of the School of Public Health for National Taiwan University and former minister of health. So from the office of the president, he was like washing his hands. He was telling people, you know, when to wear a mask, when not to wear a mask. He was giving all this education from the podium. And then certainly the command center, every day they give people information on how to take care of themselves, and they give people up-to-date information on the status of the epidemic, how many cases and who did they get it from, and every day there was at least one press conference, and it's they text everybody in Taiwan. The press conference is going to be 1 o'clock, and then everybody start to, like, you know, stop what they're doing and watch TV. So people get a text when the press conference is going to come up, and so they could know, you know, what information they need to pay attention to. Now the National Health Insurance Card also has prescription and medical exam records, abbreviated forms, not all of them, the treatment records, catastrophic illness records, organ donation and palliative care registration information, the NHI card auditing system and online service application registration. So once the SIM card, this chip goes into a computer, it activates the system for people's records. So you could get a sense of what, you know, the person has been. So this is the, you know, the president is, President Tsai Ing-wen is a female. We have a female president in Taiwan, and actually we hosted her twice here at Stanford. She was here. And that's a vice president. And so the president is always giving the podium to the vice president because he's really the expert in this area. And then on the right is the command center, the minister and the head of the CDC and the head of the academic advisory board. And they are all doctors trained in infectious disease, and the minister's not, but he's a dentist actually, but a very well-trained public health practitioner. So they give daily press conferences. Now this is, now people start to develop these apps that tells you, you know, the government now ships 600 masks to each of the locations at your local drugstores. And then people develop this app that, you know, the inventory, you know, if it's 50% or above, that they, you know, that means they still have 300 masks, then it's showing in green. If it's, you know, in yellow, it's 20 to 25%. So if you're in a neighborhood, you know where to get masks because you want to go to the ones with inventory. So this make it more convenient for people. So this is a foreign press conference that they gave to all the diplomats that are currently in Taiwan from other countries. And look at the distance they're keeping with each other. Like nobody was sitting really close, right? This is our press conference here in the United States with Dr. Fauci and President Trump touching the same microphone at least 5 times for each press conference. And it's just a little too close. And these are very important people. One is the most knowledgeable person, one is the most powerful person. So you don't want them to be spreading viruses, and the people in the back are also really, really close. So every day I watch this, I get really worried that somebody is gonna get sick and this entire team might be in trouble. So this is how they do disease surveillance. So basically they quickly figure out the imported cases. And the first ones are from China, Hong Kong, and Macau. They're Taiwanese business people coming back. And you could see that there are family clusters here, and then there are hospital clusters. And so more recently, because people extended vacations, right? School started late. So people started to go on vacations in Europe. So a group coming back from Turkey got it. And then a group that came from Spain got it, from Egypt got it, Australia and Czech Republic, and then Germany, Greece. I mean, basically people were not, doesn't have the alert that maybe Europe has it. But people think that this is only in Asia. No, that's not correct. I think that the difficulty with this type of epidemic is that you don't know who has it. And in some cases, no symptoms or very mild symptoms. So you got to be vigilant. And there are some local infections, and so they're able to track these infections. So for each case, they track about 300 contacts. So right now there's 108 cases. That means 108 times 300. That's an amount of work to do contact tracing. On average, for each person, you've been in contact for 300 people. So 108 times 300. So you could see the burden on the public health system. That's why we ask people to stay home right now. That's the best thing that teenagers could do. You know, you should tell your patients all the time. Social distance, really, because if you have to track down their contacts, we can't do it here. So this is the what's happening with the polls. So the team led by the Minister of Health, the command center, has support of 84%. This is from the polls. So most people support their actions, 84%. And the president's polls are in the 70s, and the premier and the vice premier, the executive team of the government. And so in general, even though they had fought a contested election in January of 2020, the country was able to pull together and to fight the virus. So I think this is an important lesson. The challenges coming up. So tackling COVID-19 as a non-member of the WHO for Taiwan is very difficult. It's almost like when people are having a meeting and they all go into a room and Taiwan is left outside, and people say, oh, we'll tell you later. We'll tell you when we have a meeting. We'll tell you the summaries. So it's very difficult to get, so for example, information about the virus, the viral strain. You have to like borrow a viral strain from somebody and to develop, you know, antibodies to detect it, or to do PCR, you need a primer to develop vaccines. And certainly to share practices like what Taiwan is doing, you want to share those practices to the rest of the world very quickly so that people will know that this is a very dangerous virus and you got to act quickly. Now, even as the US closed our borders here, the WHO still says, hey, no need to close borders. And that's not what we learned from Taiwan's experience, certainly. They have been fighting social media disinformation from China, and you know, they've been preparing for it because of the presidential election, and so they were fighting disinformation. So they had a mechanism set up to continue to fight disinformation, and continue to detect, and contain new imported cases as people are now going to Taiwan to seek refuge. So they become the victim of their success. So now the schools in the US are all closed. All the Taiwanese Americans living in the US wants to go to Taiwan because they feel it's safer. So in one day, they had like 10,000 people showing up in the airport. So now it's a new challenge because now you have people actually wanting to be there, and you have to screen everybody and quarantine everybody for 19 days. So if I were to take my family there, they couldn't get in because they're Americans. So only Taiwanese nationals could get in. There is a balance of using emergency powers and maintaining civil liberties. And this is an active area where I'm currently working with Michelle Mello trying to identify some of those key things that we should pay attention to. So let me just summarize what we have done here. In order to do something correctly, you have to have logic. And logic comes from having good suspicions of what's going to happen and what will happen. And so you could trust the WHO, but you have to verify. And the sequence of doing things, basically, you need to figure out what to do first. So I tell people that we have 44 million masks. Then people did a quick math and say, we're going to stop exporting the masks. So the sequence is important. And the tempo, how quickly you do things, is very important. So basically, you get the tempo right. And then you have to be able to communicate to the public. That's the articulation. So it's like almost like a conductor in an orchestra, right? You have to make sure the first violin plays the same tune, the second violin. When does the cello come in? And you have to be a good conductor, and that's the role of the command center. So this article has received a lot of press, 146 news outlets. I think I've done 60 interviews, about 4 a day. And so for the first time, my mother actually knew what I was doing, because she kept on asking me, you only see patients one day a week? What do you do for the rest of your days? And now all her friends are telling her what I'm doing for the rest of my time, which is actually a little bit comforting. The best part is Ricky Martin thought it was good. She wrote it on his Twitter account, and I couldn't understand it, so I had my former student, Ali Barrero, a Stanford resident, translate this for me immediately, and apparently it's good. So with that, I'll take questions. I think this is the last slide. Thank you.
Can you hear me?
Yep, I can.
Hey, oh, Jason, this was really wonderful, and congratulations. I think you've set an all-time record for attendance for Grand Rounds, and we've got lots of great questions. So I've been tracking them and sort of cataloging some of them. So first question, how important was having a national health system to Taiwan's response? And how should nations without a national health system gather data for surveillance and tracking?
Yeah, I think having a national health insurance is helpful, but not necessarily the solution, because even Canada has a national insurance system, and UK has one, but it's the data, like how are the data linkable, and also in the US, because we're so big here, so really we could, for example, if I were to do it here at Stanford and Santa Clara Valley, right? So we quickly get our local hospitals to share data with the command center. And then, you could, Nigam Shah, I think, is doing that with his team, trying to integrate as much data as possible. And also even our own hospital data, you could already do some of the triage before patients come in. If they're on the schedule, you could actually send them a short questionnaire to triage to see their risk factors. Then you could triage a patient flow a different way. So what you want to do is you want to keep the patients at risk of infecting other people through a different route than the patients that are very sick in the hospital, like the cancer patients. So you want to keep them separate. The other thing is that what Taiwan is now doing is that they are making sure the people practice in teams in the hospital. So they say you practice with your team. So if your team member gets infected, your whole team gets quarantined. But if you practice with the rest of the hospital, where you go around the different parts of the hospital, then the whole hospital could shut down. So you gotta just basically organize it that way. Yeah.
All right. What type of partnership can we have between California and Taiwan for COVID-19? For example, can we import the mask production lines from Taiwan to make masks for California?
So the quickest way is so if you have to set up a production line here, it will take several weeks, and then the raw materials, you have to ship them here. So the fastest way is to have them make it and just have cargoes of flights just flowing in. But as I told Mary before, I've been trying to help Stanford source some of those masks from Vietnam and Brazil and also Malaysia. So we have to act quickly, otherwise they'll be gone. So
Yeah, no, thank you. There's been a lot of questions about masks, and I'll just say that there's a dashboard that the hospital and the school leadership look at every day for every kind of PPE, how many days on hand if our burn rate triples. But the people who are overseeing all of that are working with Jason's contacts and sourcing things. So this may turn out to be a really great for us. The next two questions I think are a little bit related. So how are these recommendations from Taiwan's experience being communicated, if at all, to our government leadership? And which aspects of the Taiwan model do you think are the highest priority to implement here, given our current crisis?
Well, I think for us, we have to set up local command centers that work with the governor's office, and the governor's office has to work with the federal agencies. And so we have to act based on data. Right now, we have so few tests that we don't even know what's happening in our community. Like, we have no sense of how many people in the community are affected by this at the moment. So we have to get the test up, and I think a lot of people are working with that. There's a lot of partnership now with Google and Stanford and UCSF, and also Bonnie is actively working with the Google folks now, and we're all ready to help, but only when people need us, we're ready to jump in. But it needs to be coordinated so that it doesn't appear that it's going everywhere. It needs to be in sync. So it's very important that somebody is in charge of that. And managing capacity is very important, and distributing to the front healthcare workers is extremely important. Otherwise, if everybody gets sick, our hospital will crumble, for sure. And just take from the Hoping Hospital. They shut down the entire hospital and lock people in there. It's terrible. Yeah.
Okay. All right. I'm just watching some of the new questions come in. Okay. So somebody said this presentation was masterful, deep, and worrisome. So I'm sorry. So what are your recommendations for the U.S. at this stage? Maybe we've already, I don't know. Is there anything else you wanted to say about that?
Yeah, my friend Bob Brook, who wrote the article with me, and I'm getting a lot of inquiries about primers for U.S. health departments and institutions, and hopefully we could put that out quickly. Certainly, if you take the supplements and table supplements from my paper, there are all these action items that could be adapted as a checklist. So each community, you say, okay, what are you going to do with capacity? Counting up all the inventory and then distribute it. What's the plan for that? What's the plan for using data? Can we hack something together very quickly to triage people into different workflows? Can we organize the way we set up the hospital quickly? And so I think, like schools, so in Taiwan, if there's one person in a class that has contact with a COVID-19 patient, that class gets suspended. If two people in the school, the entire school gets out for 14 days. But that would be different here, because in Taiwan, the student stays in the same class. The teachers come to them to teach different subjects. In the US, my kids, they go to different rooms every period. So one person has it, the whole school has it. They eat lunch together, they share food. So I'm sure, the whole school has it. So we got to have a different policy. But it's a way to think about a framework of how to deal with it very quickly, a checklist. So look at the major categories of things and then create a checklist for that. And I think that will probably be the fastest way.
No, thank you. So there was a comment that the people wanted to make sure that the presentation was widely available, Jason. So we'll make sure this is posted, but we'll also post your JAMA paper as well as the table that goes with it, because it's that checklist of like 124 things that's really the most impressive. Okay, how did Taiwan handle non-COVID related healthcare needs, outpatient visits, elective procedures, etc.?
Yeah, so a lot of the elective procedures are canceled. Now, COVID-related cases are triaged to certain hospitals, not all of them. So basically, you take a third of the hospital or half the hospitals, only these hospitals could take care of COVID patients. And then the rest, their business as usual. But then because the supplies issues, a lot of elective procedures are canceled. Now, Taiwan currently has no shortage of PPEs. That's why they're giving it out. They're giving it to the United States because they're making more. So all the hospital staff, they feel like they have enough PPEs, but it's just the doctors are overworked because they have to take care of COVID-19 patients, and so it's like twice the work. So they have to cancel some procedures. Doctors have to stay healthy, and nurses in particular, the most overworked people. So we have to make sure that to take care of the healthcare team.
Thank you. There's a question here about how are we as a profession advocating to the top levels of government to implement some of the things you're mentioning. I'll mention just briefly that Bonnie Maldonado, our Chief of Pediatric Infectious Disease, who's really on point for COVID across the entire enterprise here, is in not daily calls with the CDC, but she's also talking to people on task force at the White House. So what we'll try to do is when Bonnie is here next week, we'll find out more around what she's doing, and then I'll also connect her with Lisa Chamberlain, who's the Associate Chair for Policy and Community Engagement, and see if there's any way we can try to figure out how we can all participate in some of that. Okay. Jason, did Taiwan implement mandated quarantining for hospital patients and/or need to ramp up mobile cabin hospital bed space as was done in Wuhan? And should this be implemented here?
Not this time, because they were prepared, but they are mobile units that previously has been implemented for earthquakes, for example. Taiwan has earthquakes, so when they could quickly put together like a building. In fact, Hawaii can too, right? I went to Hawaii. There's all these prefab, buildings and all that. So you just need to make sure that you have these prefab things to house people that already got the design. You know how much material you need. So I think we could do it in this country.
Okay, I know normally we're careful not to run long, but I figure we might as well get a few more questions answered, obviously, since people can log off if they need to. Right now, there are many job openings at Safeway, Domino's Pizza. What type of protection should be in place for those workers? I don't know if we're getting a little into more Bonnie's territory, but go ahead.
Yeah, sure. So I would recommend, so if you order takeout, so first of all, the person delivering it, should probably, wear gloves and masks because they're going from house to house. And when you get the food, you should probably wipe the outside of the food. And if it's a hot food, you could heat it up again, or toast your sandwich again, and just use your own container and wash your hands before you start putting in your mouth. So I think takeouts are okay, but we just need to figure out the safest way to do it. But basically, it's hand washing all the time and making sure that people who are handling the food, if you could heat it up again, it'd be great.
Okay. There's a question here, and Jason, I think this might be a little bit more for me than you, but maybe we can do it together. And that is, does it concern you that there's not yet a unified response for how to handle ambulatory clinic visits? So we have a call every 5 o'clock now for all the clinical chiefs across Packer. There's 35 of us. And Bernie, who's our chief of the emergency department, gave a presentation to the group yesterday. We sent a construct for how people should be handling their ambulatory visits. We've developed it together with Denny Lund and the hospital, and that was sent to all the chiefs last night. I don't want to go through all the different components of it now, but I do want people to know that we are very much trying to be consistent across all of the 35 clinical chiefs that exist across all the different departments in pediatrics. There's also a question about, with limited masks, should we default to surgical masks and save N95 to confirmed ICU cases? There's a committee that met 3 times yesterday, Bonnie very much is involved with all of this. There were multiple committees yesterday about this in terms of which types of masks do you use in which different settings, and it has, it's all kinds of issues about aerosolizing when you're doing intubations. There's many different considerations, and so there's recommendations that will be harmonized and approved at cost today, which is a clinical operations steering committee with a flow chart exactly when do you use an N95 and when do you use a surgical mask. And we're just trying to be think about how to conserve resources and not use things unnecessarily. But I hope for everyone there's a much clearer data-driven algorithm. There's also a number of different national societies that are coming out with recommendations now, anesthesia, surgery. So it's a very active, process right now to harmonize all of that. Okay, Jason, I'm just gonna scroll this one last time. So the CDC is now recommending alternatives to surgical and N95 masks given our critical shortage, such as cotton scarves and bandanas. How can we bridge the gap between CDC recommendations and the lessons we're learning? I don't know.
It's a Bonnie question, maybe.
Yeah, some of this is a Bonnie. And somebody asked me about homemade cloth masks for outpatient use. Is that also a Bonnie question?
Probably, yeah.
So yeah, there's a number of questions here that I think probably will circle back to Bonnie. What we'll do, everybody, is I have all the questions. We will get answers for all of them as much as possible for the ones we didn't get to. And we'll post the recording, Jason's paper, the table that goes with it, and the answers to some of these questions on the department website. All right, with that, I think we're out of time, but thank you, Jason. That was just wonderful.
Thank you so much. Thank you.
Thank you to Serena, Eunice, and everyone that made it possible.
Stay healthy.
You too.